Okay, I'm gonna let everybody in. Ready?
Yep.
Yes.
Okay, I did not see it on Facebook though. Wait a minute. Let's look again. No, it's live streaming. Does anyone have Facebook page up?
Yes, it's open.
Do you see?
Yes.
I do not see us.
I do.
Oh, okay. Then go right ahead.
Yes, Bianca.
All right. Good evening, everybody, and welcome this Wednesday evening. This is the Trenton Alumni chapter of Delta Sigma Theta Sorority Incorporated Health and Wellness Breast Cancer Awareness Virtual Forum. Because we are all loving each other from a distance, this time around, we are doing our due diligence and bringing pertinent information to our community virtually. This evening, we will have Dr. Coral Omni from the Rutgers Cancer Institute of New Jersey, as well as several breast cancer survivors who are going to share some details about their journey. Just a couple of housekeeping tips for the evening. We are asking for those who are joining us via Zoom to remain muted, as well as your video off at the time, as well as if you have any questions, you may enter them into the chat during our question and answer period. We will also ask that you all complete a survey. I'll be entering it through the chat several times throughout the event that you can go in and complete the survey at your earliest convenience. And if there's no other housekeeping things I need to cover, I am going to turn this over to Dr. Omni.
Thank you. Thank you. Good evening, everyone. Thank you also for the invitation to come, especially during Breast Cancer Awareness Month of October. It's a very important month to really emphasize all the information we can get out for breast cancer. So I'm very happy to be here. When I guess I should share my screen now. Hold on. Can everyone see that clearly? Yes?
Yes.
Okay. So when I was contacted to come here tonight, I believe the main goal of this forum was to share some key facts about breast cancer and certain myths about breast cancer. So I hope to be able to do that today. So the title of this talk tonight is Breast Cancer Awareness, Facts and Myths. First, I would like to go over the outline of the talk today so you can follow along. I'm going to start off with the background of breast cancer. I mean, some of us may not know all of the key statistics and facts. So for those who already know this, bear with me, but I'll go over the background and then move on to screening and evaluation of how one detects breast cancer and what that entails. Talk about treatment overview, focus on the different subtypes of breast cancer and the treatment options within those types of breast cancer. Okay, it wasn't moving before, now it's moving. So breast cancer is the most common cancer among women other than skin cancer. It's the second leading cause of cancer death in women after lung cancer. And the chance of a woman having invasive breast cancer in her lifetime is about 1 in 8, and the chance of dying is about 1 in 33. Sadly, over 200,000 women in the US develop invasive breast cancer every year, and over 40,000 of them will unfortunately die from the disease. In terms of those who pass away from disease, they tend to comprise of metastatic stage 4 breast cancer patients. And this is typically breast cancer that has spread beyond the breast, most often to the bones, lung, liver, or brain. Metastatic breast cancer usually develops when the cancer returns at some point after the initial breast cancer diagnosis and treatment. However, even though that's the case, usually about 6% are considered de novo metastatic breast cancer, meaning that at the first instance of diagnosis, they have already reached a metastatic status. And that's compared to about 6%, which totals about, it changes slightly every year, but the average is about 154,000 people who have metastatic breast cancer in the US living with this disease every year. So in terms of the risk factors, can you see the entire slide? Because on my screen, I only see about 70% of it. Are you able to see my entire slide? Okay.
Is the last bullet point lifestyle?
Yes, okay, good. So in terms of risk factors, I want to highlight the key risk factors, common risk factors, and take this opportunity to highlight some myths about risk factors. So obviously being female is a risk factor, right? However, this is a myth. The myth that it only occurs in women. Men can also get breast cancer. They comprise only about 1% of cases, but it can occur. And when that happens, that should be definitely be evaluated because there might be genetic predisposition in that family, possibly. But it does occur in men. Yes, being of older age is certainly a risk factor. If you look at the trends, there's sort of a linear correlation between getting breast cancer and the risk is higher the older you get. However, this is also a myth that it only occurs in older women. There are women less than 50 years of age, 40, in their 20s and 30s who get breast cancer. So it has to be taken seriously at all age groups. Early start of menstrual periods as well as late menopause sort of focus on the same theme where the woman is cycling her menstrual periods for a longer period of time. So she started early and she entered menopause late. So that hormonal cycling, length of time uninterrupted, essentially predisposes a woman for breast cancer. Then of course, we have the genetic risk factors, the famous ones, that common ones that most people know because there's certain celebrities that may have them at the BRCA1 and BRCA2 mutations, which are the breast cancer genes. And of course, a mutation in these genes leads to very high risk for breast as well as ovarian cancer. And there are other cancer groups that segregate with this genetic mutation as well. But there are other two genes that are also possible to contribute to risk factor predisposition for breast cancer, and that includes CHEK2 and PALB2. There is a myth that I've heard where patients say, well, I don't have the genetic mutation in my family. Maybe my cousin got tested and they don't have the gene, so it doesn't run in my family. That's not true. Genetic mutation in either of the breast cancer genes only comprises 10% or less, anywhere between 5 to 10% of all breast cancer cases. So the majority of breast cancer is actually patients who don't have any genetic mutation. So that's a myth I hope to dispel tonight. Similarly, a family history, while that is true, that the more patients or people may have several family members with breast cancer, and that may elevate their risk. The myth that I've also heard is people say, well, it doesn't run in my family, and women are surprised. Well, how could I have it? Doesn't run in my family. There's no family history. So just like you don't have to have a genetic mutation, you don't have to have a family history of breast cancer. There are many women who they are the first person in your families going down several generations that they're aware of that have been diagnosed with breast cancer. Obviously, a personal history of breast cancer predisposes one, it puts them at a higher risk than the average woman for a future breast cancer. Ethnicity plays a role, and I will talk about that in detail further later on. Lifestyle, and what do I mean by lifestyle? It includes, for instance, a late age for having a first child, the use of oral contraceptives, hormone replacement therapy, obesity, excessive alcohol use and smoking. All of these lifestyle behaviors tend, some higher than others, but they all contribute to risk of developing breast cancer. Now, I just want to take you through the female anatomy. It's important as we go along where we talk about the different types of breast cancer. So typically, the breast consists mainly of fatty tissue, as you can see, with connective tissue. And then the less conspicuous parts include lobules within the breast, ducts, which are the nipple ducts that carry milk all the way down to the nipple, and lymph nodes, which I'll talk about shortly. The lymph nodes constitute the lymphatic system, which includes the lymph ducts that feed into the lymph nodes. Now, the lymph ducts drain fluids typically that carries white blood cells that fight disease from the breast tissues into the lymph nodes under the armpit and behind the breastbone. The lymph nodes filter the harmful bacteria that may be passing through, and they play a key role in fighting off infection. And so this network of vessels drains from the breast and outside of the breast, starting from underneath the armpit and over the collarbone. And so this is important because breast cancer cells then would typically drain from the breast into this lymphatic system and then go outside of the breast into the rest of the body. So this brings me to the signs and symptoms of what to look out for when you suspect breast cancer. So the typical most common sign is a lump or thickening in the breast, which is often painless. But this is also a myth that it will always present as a mass or a lump. If that's not the case, as you can very well see from the picture I have in front of you, it can appear as a discharge or bleeding from the nipple, change in the size or the contours of the breast, nipple inversion. And this is important because some women might just think, oh, that's odd, you know, the nipple just sort of turned inward. That could signify that there's a tumor behind the nipple in the breast that's tugging on the nipple and pulling it inward. Similarly, a change in the color or appearance of the areola, which is typical, this sort of peeling, flaky, crusting appearance, is also abnormal. And finally, a swollen red appearance of the breast, such that it leads to this pitting of the skin, and so that it looks like the skin of an orange. This is actually an aggressive presentation of breast cancer called inflammatory breast cancer. And every one of these signs and symptoms on this page should definitely be evaluated immediately because it's highly suspicious as breast cancer. So what are the causes to make for breast cancer to form? So lots of patients ask this question. Okay, there is no one cause. The bottom line is that unfortunately some of the healthy cells in the breast just begin to grow abnormally. So over time they may, develop mutations over time, and eventually the mutation load is such that it becomes cancerous. And so when that happens, the cells divide more rapidly than the healthy cells do. And then they now spread through the breast, as I've showed you, to the lymphatic system and to other parts of the body. So at that point, it means it has metastasized. The most common type of breast cancer begins in the milk-producing ducts I showed you, but may also occur in the lobules on the other parts of the breast tissue. This is me to the myths about the causes of breast cancer that we have heard. Common ones being wearing an underwire bra can cause breast cancer, or using deodorant. These two are false, okay? So while wearing an underwire bra may cause pain sometimes, depending on how tight it is, that doesn't then lead to, over time, breast cancer. Similarly, I hear using deodorant and people talk about they've had chemicals in deodorant like aluminum may cause breast cancer. While, yes, there have been some studies that show that the aluminum from the deodorant can be found maybe in the lymphatic system and in the breast tissue, there is no data, no evidence that then leads to the development of breast cancer. So that myth has been dispelled. But there are other non-cancerous conditions that may mimic those appearances, and it's good for women to know what they are, be able to tell the difference, but also to be able to know when to go and get evaluation. So the first one, the fibrocystic changes, and this typically is lumpiness and thickening and swelling, which is often associated with the woman's period. Those are normal sort of lumpy changes that are found in a woman's breast. Cysts, these are typically fluid-filled lumps that can range from very tiny to about the size of an egg. And it can be uncomfortable, but it's usually benign. They're just filled with fluid and they can be drained easily. Fibroadenomas. Fibroadenomas are a solid, round, rubbery lump that moves under the skin when touched and occurs mostly in young women. That too is benign. And infections, and this is an important note. Sometimes when there's an infection in the breast will present as red, warm, tender, lumpy. And this can look like the inflammatory presentation I showed earlier, which I said is an aggressive presentation, that sort of red, warm, swollen appearance. One cannot know what it is, and that's why when you see that, you definitely have to go and get evaluated immediately to determine whether this is, say, a harmless infection or worse. Trauma. So trauma can cause a lump to the breast or a bruise that may take a long time to heal. And so when that happens and there is an actual history of trauma, then you know that that's what led to that appearance in the breast. So those are all non-cancerous conditions. And finally, there are what we call microcalcifications. And these are tiny deposits of calcium that can appear anywhere in the breast and often show up on a mammogram. And most women have one or more areas of microcalcifications of various sizes in their breasts. The majority of calcium deposits are harmless, but a small percentage may be precancerous or cancer, which is why the radiologist will sometimes say a biopsy is recommended, depending on how suspicious it may appear to them. And I will show you some pictures of that coming up. Now, I want to segue from suspicious, appearance to the importance of detection, because yes, we can look on physical exam and detect suspicious signs or symptoms, but many women will have or present with breast cancer that have no abnormalities whatsoever from a physical exam. And so detection is key. And the way to go about doing that is to keep up with routine and regular screening. The goal of screening tests is to find cancers before they start to cause symptoms. And early detection means using an approach that allows earlier diagnosis of breast cancer, which can then be treated successfully. And it's definitely been shown that early detection tests for breast cancer save many thousands of lives each year. Now, there are different guidelines for screening that are out there. And we as oncologists, we tend to follow the American Cancer Society. The American Cancer Society, as of their most recent guidelines and updated guideline version, recommends that women get annual mammograms starting at the age of 40. It can be offered to them. Before, it used to be required as a must from the age of 40. Now it says it can be offered. So anywhere age from 40 to 44, you can get an annual mammogram, but it's not required. However, by the age of 45, it is required to have annual mammograms. And then from the age 55 and older, it's recommended that you can get it every 2 years, but you can still have the option to get it yearly if you want. And they recommend screening women as long as they're in good health and expected to live 10 or more years or longer. So I have, patients that are 70-something years old. Yes, you can get, you're young and you're fit, and your life expectancy is at least 10 years or more, then definitely continue on with annual mammography. Now, if you're 90, then it's most likely, not advantageous to go every year for mammogram. So those are the guidelines. Now, for those who are at high risk for breast cancer, there's enhanced surveillance for this woman, for those, for instance, who have genetic mutations. And that includes getting an annual MRI plus an annual mammogram spread about 6 months apart, so that woman is getting her breast imaged every 6 months, either with an MRI or a mammogram. And of course, if there are any about suspicious areas found on physical exam or mammogram, breast ultrasound is another modality that's added to a mammogram to be able to determine best what type of cancer, or if it is cancer. Now, what exactly, as mammograms? So many of you may already be aware of this and undergo screening, but for those who are not familiar, this picture on the left is a picture of a typical mammogram. And what the mammogram machine does is essentially emits low-dose X-rays to examine the breasts. And the digital mammography then converts these X-rays into electrical signals, which produce images on a computer screen for the radiologist to review. And mammography can actually show changes in the breast up to 2 years before a physician can feel them, and is very efficient in diagnosis of breast cancers at an earlier stage. Having said that, though, there is a myth that mammograms cause cancer. Mammograms do not cause breast cancer. I think people generally hear the words radiation, and get scared, but the X-ray dose is so low. It's so low that the risk of developing breast cancer over the life of that patient is so low from the exposure. And essentially the risks are, the benefits outweigh the risks. And so there is no evidence that mammograms cause cancer. I mean, I think flying in a plane, you're exposed to more radiation than that, actually. So that's a myth I hope to dispel. The other myth, though, is that the mammograms are a guarantee that cancer will be found. While it is the best screening modality that we can use routinely, the others like MRI and ultrasound are additive, so additional modalities to enhance mammograms if there is a doubt about the findings. Because unfortunately, there are some breast cancers that are called mammo-occult. So occult meaning they are not detected on mammogram. So sometimes a woman may come in and they have obviously what is a mass or a lump in the breast, but the mammogram says there is nothing there. And that's when you definitely need an ultrasound. And sometimes it can be found on ultrasound. Sometimes if it's not, then an MRI is the best option to then figure out exactly what's going on. So mammograms, best for screening, but it's not a guarantee that cancer will be found, which is why we have to pay attention. And usually clinicians know to pursue all avenues in terms of for diagnosis if there is any concern. So in terms of mammographic evidence, these are pictures of what I have been talking about. So masses are typically what you would see on the mammogram, as you see here on the left lower corner here. This is what they appear for the radiologist to review. The microcalcifications, which are the tiny flecks of calcium, which look like grains of salt on the imaging, can sometimes indicate early cancer, and this is what they look like. And here is a picture of what a patient with breast cancer looks like, because it does not appear as a mass, but you can definitely see the calcifications. And of course, either of these warrants a biopsy. And typically that biopsy is sent to a lab where pathologists would then review it and describe it and characterize it so that the oncologist can now determine what type of breast cancer it is and how to treat it based on the usually very detailed report from the pathologist. So that brings me to the stages of breast cancer, because now we're going to talk about different types of breast cancer. But starting off with the stages, I think everyone knows, or hopefully maybe already aware, that stage 4 means metastatic, which is unfortunately currently incurable. But from stage 0 to stage 3, we consider that early stage, and we consider that curable. So now we'll talk more about that. Stage 0 is called ductal carcinoma in situ, or DCIS. Now, going back to our female anatomy figure, this is what the zoomed in view of a normal male duct looks like over here. Now, DCIS are cancer cells that are growing inside the duct, but they haven't invaded outside of the duct into the breast tissue. This is what it will look like when it breaks through the basement membrane and invades out of the ducts and then invades into the breast. And then that's called invasive breast cancer. DCIS is non-invasive, stage 0, and surgery alone or combined with radiation therapy or endocrine therapy or both is what is sufficient. No chemotherapy is ever used in the treatment of DCIS. And this typically carries an excellent prognosis, up to 99% accurate. For early stage breast cancer, going back to our figure, this is, as I've mentioned, the cells have broken through the basement membrane out of the milk ducts and have now invaded the breast tissue and then carried out by the lymphatic system to regional lymph nodes under the arm and above the collarbone. And when that happens, we consider that locally advanced or local regional. And the stages depend on how many lymph nodes are involved, right? So obviously the bigger the tumor and the more lymph nodes that are involved, the higher the stage. But in any event, as long as they fall within stage 1, 2, or 3, surgery alone or combined with radiation therapy for local control, as well as systemic treatment with chemotherapy and targeted therapy, all that we use for curative intent. And the prognosis depends on the extent of locally advanced disease. So obviously stage 1 has a better prognosis than stage 2 and 3, with stage 3 being the worst of all the 3 stages. Stage 4, unfortunately, is currently not curable. And this is, as you can imagine, breast cancer cells that have invaded the breast, left the breast, and have now migrated to either the brain, lung, liver, or the bone. And the treatment goal is to control the disease and typically focuses on the length and the quality of life. We use chemotherapy, hormonal therapy, targeted therapy, clinical trials for treatment for this stage of breast cancer. And we use surgery and radiation as needed. Some patients may live many, many years with metastatic breast cancer, although that depends on the type of breast cancer. So this is an overview, just to reiterate what I just said. In the early stage, treatment goal is curative. The 5-year survival is between 70 to 90%, depending on the stage of breast cancer, while in the stage 4, late stage breast cancer, the 5-year survival is typically 25% and below, unfortunately. So the types of therapies that we use in breast cancer can fall into 2 camps, chemotherapy or targeted therapy. Chemotherapy are potent drugs that acts on all rapidly dividing cells, while targeted therapy was specifically designed to act on specific molecular targets that are important for the tumor. Chemotherapy was typically identified in the laboratory because they're potent and they can kill cells. And typically, you want to use compounds that can kill the cell at the lowest concentration, but they kill all cells. They are not targeted, as opposed to targeted therapy that are designed to interact with a specific target. And because of this, the mechanism for chemotherapy, it can actually harm both tumor and normal cells, which is why women unfortunately have more side effects from chemotherapy, as opposed to targeted therapy where you're targeting specifically the tumor cells. And so it's not as harmful to normal cells, and side effects are usually much less for targeted therapy. So in terms of treatment, that was an overview and sort of how we think about treatment. However, treatment is tailored depending on the type of breast cancer. And that brings to this myth that all breast cancer is the same. It is not. We'll go through them. So in general, there are three main subtypes of breast cancer. There's the hormone receptor positive breast cancer, which the hormone refers to the female hormones estrogen and progesterone. There's the triple negative breast cancer and the HER2 positive breast cancer, which are both aggressive forms of breast cancer. But within each type of breast cancer, there's heterogeneity, such that there are subtypes within it that actually guides management. For instance, a HER2 positive breast cancer can also be a hormone receptor positive breast cancer. And so that woman will then receive treatment for both types of breast cancer. So we can take them one by one. The estrogen receptor positive breast cancer. So here, this figure sort of signifies in green the female hormones estrogen and progesterone that's surrounding the cancer cell. The triangular receptors, or the estrogen or progesterone receptors on the breast cancer cell that bind to these female hormones, which then drive its cell division. The HER2 overexpressing breast cancer cells essentially overexpress, make too much of this protein, while the triple negative breast cancer does not have the estrogen receptor, the progesterone receptor, or the HER2, which is why it's called triple negative. So taking each one specifically, for the hormone receptor positive breast cancer, it comprises actually the majority of all breast cancer, so about 75%. It grows in the presence of the female hormones, but however, approximately 30% will experience relapse with metastatic disease after curative intent treatment. And what is sort of typical about this subtype of breast cancer is that it can recur up to 15 years or more after initial diagnosis, which brings me to this myth that some women may have, that once treatment is over, nothing further is warranted. So that's not the case. Continuous surveillance, continuous physical exam and interactions with your oncologist, being aware of what's going on and getting annual mammograms, all of those, reporting any concerning symptoms, all of that has to continue. Obviously, the further one gets away from diagnosis, one can feel more comfortable, but in particular for this subtype of breast cancer, there is that risk still, even up to 15 years or more, and which is why the vigilance must always still be there. And typically the therapies that are used are medications that block the hormonal pathway, as you can imagine. So tamoxifen, for instance, prevents the action of the female hormones on the receptors. Aromatase inhibitors actually prevent the formation of estrogen from other hormones. So essentially decrease the level of estrogen around. The estrogen degraders, of which this drug is a part of, actually degrades the receptors. So the receptors are internalized into the cell, so they're not available to bind to the hormones. And CDK4/6 inhibitors, which blocks through a different mechanism, but acts in concert with the female, with the hormonal targeted drugs. So this subtype of breast cancer, there are actually many drugs that we have on hand to be able to target for this disease, which is quite reassuring. For HER2 positive breast cancer, like I mentioned, this is an overexpression of HER2, HER2 being actually what we call an oncogene, meaning that it likes to cause cancer. And so when there's too much of it, it definitely will then develop into cancer. In this case, if it happened in the breast, it develops breast cancer. For HER2, it comprises 20% of all breast cancers. And like I mentioned earlier, it's very aggressive and spreads readily. Many years ago, before drugs were manufactured for this type of breast cancer, women used to die at high rates, the high mortality rate for this disease. But since then, there's been great advancements in targeted therapy. So there's a slew of drugs that have been developed over time that have been very exciting, such that we see for this type of breast cancer, the mortality rate has gone down significantly, and women are surviving and doing so well, even though they have this aggressive biology subtype of breast cancer. And some of these drugs, like tucatinib and trastuzumab deruxtecan, were just FDA approved earlier this year. There's a lot of options for this subtype. So it's highly treatable, and you can have extended survival in some of these patients, even in the stage 4 setting, which is very reassuring. Now, this leads me to the final subtype called triple negative breast cancer, as I mentioned, that doesn't express any of those markers. And it comprises about 10 to 17% of all breast cancer. And it's more prevalent among young African-American women and women of African descent, as well as women from the Caribbean. And as you can imagine, this is because, from West Africa and Sub-Saharan Africa, where a majority of the slave trade was done, those geographic location and migration through the slave trade down to the Americas and down to the Caribbean, which is why we have that biological connection where you tend to see more triple negative breast cancer in this population. And unfortunately, it happens for younger women, and it's very aggressive than the other subtypes, highly metastatic with poor survival. And a lot of that, it's because there are limited treatment options. It's really an unmet need for this subtype of breast cancer. Having said that, though, there's reason to be optimistic because there's a lot of research being done for this subtype, because everyone knows how dire the need is. And I'll share with you that there are actually some drugs that have come out on the horizon in a couple of minutes. But what I wanted to just bring to your attention was the risk factors that are associated with triple negative breast cancer, because some of these are actually the opposite of what we spoke about earlier in terms of the common risk factors. So just to go through, obviously being of African-American race predisposes you, one, to triple negative breast cancer. Being younger, premenopausal, predisposes you more than if you were postmenopausal. Increasing parity, now this is interesting. Typically, in general, the less pregnancies you have, or in fact never having been pregnant or having children, just means that that woman has been cycling her menstrual periods for much longer without interruption, as I mentioned previously at the beginning, and that leads to increased risk for breast cancer. But here for triple negative breast cancer, that's the opposite. So the more pregnancies and children you have, the more one can be at risk for triple negative breast cancer. A younger age at first-time pregnancy is another risk factor. And what's different in this subtype is that a shorter duration of breastfeeding, or say use of lactation suppression techniques so that one doesn't breastfeed, that can actually predispose one to the subtype of breast cancer. Here I have elevated waist to hip ratio. So this leads, to the lifestyle, one of the lifestyle risk factors I mentioned earlier, obesity. So obesity is associated with triple negative breast cancer, but this elevated waist to hip ratio is more thinking of the increased abdominal girth in terms of obesity so more abdominal fat in terms of the body composition. So that specifically is a risk factor also that's associated with triple negative breast cancer. In terms of the prognosis, this is just to highlight what I mentioned earlier in terms of the poor prognosis. So there's data to show that triple negative breast cancer patients have an increased likelihood of becoming metastatic and resulting in death within 5 years of diagnosis, which is why we always tell patients, you can't disappear after treatment. We have to be seeing you. We have to be seeing you every 6 months. You have to be sharing with us any issues or symptoms that may be benign. You can talk to your primary care doctor, but we also want to know about it because the risk of metastasis is high within the first 5 years. And here you can see it, actually significantly shorter compared in terms of the time to distant recurrence and overall survival, 2.6 years versus 5 years, and 9 months versus 22 months when compared to the other subtypes of breast cancer. And many women with triple negative breast cancer relapse early on chemotherapy, which can suggest resistance to the current treatment modalities, which have typically for many years been just chemotherapy. However, in recent years, because of a lot of research in this area, there have been different classes of drugs that have come out in the horizon. Most recently, earlier this year, this class of drugs called antibody drug conjugates, specifically sacituzumab govitecan, which was just approved, I believe, in the spring of this year, which is very exciting because this drug was found to have a significant efficacy for these patients, even after they have gone through 5, 6, 7 lines of treatment that have stopped working. So that's what makes this exciting. But others include PARP inhibitors or immunotherapy. Some may have heard about on television, but in essence, it's a class of drugs that essentially activates the patient's immune system to fight the cancer. And that was FDA approved for metastatic triple negative breast cancer earlier this year. And finally, in terms of further treatment options for metastatic triple negative breast cancer, in fact, all breast cancers, is what we call palliative therapy. Now, palliative therapy is a comprehensive discipline that helps with symptom management, pain control, and a host of other issues for these patients. But typically for surgery and radiation, we talk about using palliative therapy with these modalities for certain cases. So even if a patient has metastases, if they have very few small liver metastases, for instance, surgery can be offered for palliative removal. And this typically works in the subtype of hormone receptor positive breast cancer. Similarly, if the disease is spread to the brain and it's just 1 or 2, that can be safely removed with surgery, that is done as well. Radiation can control the cancer in a specific area. It can ease pain, and we use that a lot for palliative pain control. So you can either achieve pain control with medication, but for instance, if a patient has significant hip pain because of a bone met in that area, radiation can go in there and sort of burn off that area, burn the disease in that area, and that significantly relieves the pain of a patient and increases their quality of life. And radiation can be used to reduce bleeding if there is, and similar to surgery, can treat small to moderate sized tumors either in the lung or in the brain. And typically this technology is called CyberKnife or Gamma Knife technology. So essentially this is a summary of some the major breast cancer facts that I would like for you to be aware of. And I've hopefully dispelled some of the myths that are commonly attributed in some of these areas in breast cancer that we have heard or had some patients talk about. So I'm happy to also, dispel any other myths out there that you may have. And thank you for your time and your attention. I'm happy to take any questions at this point.
Thank you, Dr. Omni. That was great information that we received, some things that I wasn't aware of, and it kind of dispelled some of the things that I thought. Some things about breast cancer, you was the myth buster. And actually, I didn't do my due diligence in interviewing and showcasing who I am. My name is Bianca Taylor Davis. I am the co-chair of the Health and Wellness Committee, along with our co-chair, Monica. Nope, she's not on. But Monica Kelly, as well as our chair, Linda Wyatt Simpson, who actually I'm going to turn it over to for our question and answer and to introduce our survivors as well.
Thank you. Thank you, Dr. Omni and Bianca, for that introduction. At this time, we do have some survivors, and we are so thankful that you have survived to tell your story and have lived through breast cancer. So we would ask that you would take a few minutes and to either share your story, reflect on what's been addressed, and maybe just give some advice as a person that has gone through it. So to start off, we have Marion Hardy. And if you could unmute yourself and open your video, we would love to hear from you. Marion, are you on? Let's see if I can find her. Okay, well, I don't see Marion right now. She was on, but I will ask Michelle Hutchins Medina if she could share a few words with us. And you can unmute yourself.
Linda, she was on. She is on.
Yes, I see Michelle. Go ahead, Michelle.
Hello, everyone. Thanks for inviting me to the panel. My name is Michelle Hutchins Medina. I'm 52 years old, and I was diagnosed with triple negative breast cancer in December of 2019, and I just completed about 9 months of treatment. I had my last radiation treatment in September. So I actually had chemotherapy, surgery, and then radiation. My suggestion is that if you should happen to be diagnosed, I think it's very important to, if you have routine care somewhere, if you're not really comfortable with their oncology department, then I would say to put yourself somewhere where you can get the best possible treatment. It's okay to go somewhere else, even if you've been in another hospital system. The other thing I would say, I'd echo what Dr. Omni said, which is that no breast cancer is the same, and therefore no treatment is the same. So you have to be very careful about listening to other people's experiences or things that other people did. You have to really just understand that it's important to customize your treatment for you. I would also suggest that when you go to all these visits, because there's so many visits involved in the workup, just even before you start treatment. I actually was diagnosed December 6th, but I didn't start treatment until January 10th. And that was really because of all the different tests, the scans, the genetic testing, all those things that need to be done so that they can understand what is the best treatment course. So when you go to all these appointments, particularly the one with your surgeon or your medical oncologist, I always suggest that you take someone with you, someone who is a good listener, because sometimes you may be overwhelmed a bit by a lot of the information, and it's good to have someone else in the room that can hear that information as well. And finally, I would suggest that if you have any questions about your treatment course or when you're under treatment, any side effects or anything that you're having, that you make sure that you're in close contact with your oncology team. And I have found that the best way to do that was actually through the hospital's patient portal. They were very responsive to, if I put out questions on the portal, I didn't have to wait for someone to call me back or leave a message. And so I think that, along with my tribe, my friends, my family, having a good tribe in place is good. And that's what helped me get through.
Thank you so much, Michelle. Those words of wisdom, I'm sure will resonate with a lot of people. Marion, do you have some words for us? And you can unmute yourself. And maybe turn your volume up because we can't hear you.
We may have to unmute her, or does
She's
she?
unmuted.
She's unmuted, okay.
We still can't hear you. Let me just see if there's anything we can do. Marion?
Now?
Yes, we can hear you now.
Okay, I'm sorry.
That's okay.
September was my 5th year. I had breast cancer at age 60. I'm 65 now. And the biggest thing that I can say for me was prayer that got me through. My faith and my trust in God and my confidence in God, that is what got me through and up into this time now. I had my yearly mammograms, and because I had my yearly mammograms, that's where they detected it. And I had a biopsy, and like I say, I believe that faith is what got me through, trusting. And like she said, everybody's cancer is not the same. It's in my family. My mother had breast cancer. My sister had breast cancer. My mother has a brain tumor with cancer, but she's she's elderly, so she can't have it removed. But what I would say is I'm nervous a little bit. It's just to trust in God and believe that He'll take you through. And because if you're afraid, you know, that can hinder you. And so I think that's about all I have to say. I'm a little nervous.
Okay, thank you so much. I appreciate that. Next, we will hear from Audrey Walker, who happens to be the co-founder and director of Healing Stream, which focuses on breast cancer. Audrey?
Hi, everybody. I'm Audrey Walker, and I am a 15-year breast cancer survivor. And after speaking with listening to Dr. Omni, I realized just how blessed I am. I was diagnosed in 2004 with something called calcifications that the doctor talked about, but the calcifications was across my entire breast. What sent me to the doctor, though, I was actually trying on a bra, and I actually felt a lump in my breast. And that lump was small. It was as small as a pea, I would say, maybe even smaller. But I did feel it, called my doctor, and my doctor told me to just immediately go and have the mammogram. So when I went to have the mammogram, that's when they found this calcifications across my right breast. As for me, I fell in that 20% that the doctor was talking about, where the calcification, they were diagnosed as precancerous. So the doctor said, okay, because they're across the entire breast, we need to do surgery on your breast. So I had surgery and I had reconstruction. This was 2004. And I got through that. I didn't have to have chemo or anything because they said it was a precancer, a precancerous thing. So then the next year I went for a GYN checkup, my annual, and my GYN checked that breast and told me to go directly back to my surgeon because she felt a lump in the same breast. So I went back to him, and he looked a little strange as to how it occurred. However, he said that cancer is tricky. We do have cells, breast cells that even go to toward your back. So anyway, he sent me for a biopsy, and that was kind of the wait time during this is really something that really wears on you, because you're waiting for the biopsy to come back. You don't know what they're gonna say. However, so he got the biopsy back. He said it's cancer. He removed that lump, and then I had to go through chemotherapy, very strong chemotherapy for about 6 months. And then at that time, doctor talked about targeted therapy. They gave me Herceptin, and Herceptin had just come out of trial, and they found that it should work for me because I had the HER2 positive, which is very aggressive. So for 1 year, I had the targeted therapy with the Herceptin. And, you know, I guess for about 3 months, I went through all of these things. And yes, they do wear on you. I was worried. I was really concerned because at the time I had children. I had a 13-year-old, and I had an 18-year-old that was in college, and a 24-year-old who had just moved to another town. And it was just a lot of it. I wasn't really concerned a lot about me, but it was just about my family. And I didn't have a lot of tears for me, but I did cry for my family. And I just prayed. I stayed positive. I had a great surgeon. I had a group of doctors that were really good. My oncologist was fabulous. And like the other lady said, if you don't feel comfortable, yes, you should move. You call another doctor. And if you get a diagnosis, I did go and get a second opinion. I will say that. I didn't just go with the first opinion. I got a second opinion. And second opinion agreed with the first. So I just went along. I think the most I cried, and the chemo, you know, they told me my hair was gonna come out. But once I saw it just falling out on the pillow, it just really was very devastating to me. So, but the hospital did, they had a person. The day before I shaved my head, my husband, who I tell you, he stuck very close to me, he came home the day before I had and had his head shaved. So I thought that was just so wonderful of him. And like the other woman said, when you're going through this, your family, my extended family, they all mind around what's happening to you before, well, for me, before I could let other people know about it. But all things work together for the good of them that love the Lord. And God blessed me to get through all of that. It's not an easy road for anybody who is walking through cancer. To have a group of people that are supporting you is so, so, so very important. And what birthed out of it was the Healing Stream Breast Cancer Awareness Organization, of which I am the director now. And what we do is those little things that a person is going through breast cancer that you think are little but are really big to them, those are the areas that we go in. I mean, we sit with them, we listen, we pray with them. A lot of women, you don't know, they lose their jobs, they lose their self-worth, they lose their self-esteem. We'll take them on days of beauty. We have had people to go and clean women's homes. So it's very personal and intimate what we do in my organization. And the way that we came up with the concept is by walking through with other women and seeing the needs that they had. So that's my story. And I
Thank you
thank
very
you,
much.
Linda, for inviting me.
You're welcome, and thank you so much for that testimony. We have one more survivor that's very special to us at Delta Sigma Theta. So I would ask if Soror Karen Richardson would come on, please.
Oh, Karen.
Okay, Karen, you have to unmute yourself. Can you unmute?
Is she under another name? Because I
Yeah,
don't.
she's under Winter. Let's see if I can.
There we go.
There you go. Go ahead, Karen. We can't hear you.
My technical assistant, Winter, is doing all of my corrections and assistance here. I just want to say good evening, and I've heard some inspiring stories, and the thing that I would just add is that I would encourage people to get annual mammograms. I think it's important because a year can make a big difference. And I was diagnosed almost 8 years to the day, October 2012. And my history is that my mom was a breast cancer survivor. She had breast cancer 3 times. And although she did die of cancer, it was not from the breast. And I was fortunate. I'm sorry. I was just going to say, I was fortunate. My breast cancer was diagnosed very early. So I was only having to have, I think it was something like 32 or maybe, I'm not exactly sure, 32 weeks of radiation. And I just remember that, yes, I had a wonderful support group, which is so important. I had trust in my doctors. And the hardest thing, I think, is to ask questions, because you sort of want to know the answers, but then you don't. And I think that most of us who have survived, I know with me, when it's time for my mammogram, I'm anxious, I'm nervous, but it's something. Oops, am I back on? I received excellent treatment. I remember so much, the thing that gave me so much comfort was the warm bathrobes that they gave us to put on. And it gave me such comfort that in my last treatment, radiation treatment, I asked if I could keep it, and they allowed me to take it home. So my greatest emphasis is on getting yearly mammograms, because it does save lives. And I want to thank you all for listening to me, and my prayers for all of us as we continue to live through this disease.
Thank you so much, Karen. At this time, I would ask that, I don't see any questions in the chat, and I didn't see any online, because I think, Dr. Omni, you have enlightened us with some of those myths that I think you've probably answered most of our questions. But at this point, I would ask to turn it back over to Bianca. We have a few more minutes, and I don't know if Soror President wanted to say a few words.
We do have one question that came in through Facebook Live.
Okay.
This question, the user posed, how often should you have a BRCA test?
So a BRCA test doesn't change, right? So you either have a mutation or you don't. So once is typically enough to know if that patient has the genetic mutation that causes breast cancer or any other suspicious genes that may contribute to that, genetic disposition. However, having said that, it also depends on when they had the test. For instance, many years ago when the test, was more of a novelty, there wasn't what we have now. It's called an expanded testing, where there's a slew of genes. So before it was strictly just BRCA1, BRCA2. So now if I see a patient who says they were tested many years ago, and yes, they were BRCA1 and 2 negative, but it wasn't the expanded panel, we will send them back to the genetic counselors so that they can then do the actual expanded panel, because over the years, there are several more genes have been identified that can contribute to that increased risk. But in general, it's not getting a BRCA test or genetic test is not something like a mammogram that you get once a year. It's essentially once, typically. If you get an expanded panel testing, is sufficient. Yeah, so you don't need to get it often.
All right. Believe we have one more question from the Facebook Live that asks about family support resources. I'm not sure, are you asking whether or not there are parent support resources, or can you suggest any family support resources?
Well, so typically, I mean, there's not one family support services. So typically, at least at major cancer centers, they usually have a team. One of the survivors mentioned a team, and that can include social work, and that department can provide the patient with many support services, even for patients who have kids, to help the kids deal with the diagnosis. So they're out there, and I think it depends on where you go and what they have available or where they can refer you to. So yeah, they're definitely out there, and maybe some of the survivors have used some of any particular family support services that they would like to share. But I think wherever you go, if God forbid someone was diagnosed, I would second what one of the survivors mentioned, to go somewhere where you trust your doctor. You can get a second opinion, absolutely, because we receive people coming in for second opinions as well. And a place where they're not just taking care of the disease, they're taking care of your entire body. And that includes your wellness, your health, your mental health, where there's, psychiatric services if you need them, social services for support for other avenues to guide you for their financial help, what have you. So you need a place that can give you comprehensive care, not just focusing on treating the disease. And I think that varies from place to place, what options are available. But I would suggest, just like one will go do the due diligence of shopping, or going to different places to shop for, a car, or your home, or whatever. Similarly, just like you've heard from survivors, getting the care that best works for you. And I would suggest having a comprehensive team that takes care of the entire body would be a good place to go.
Okay. What I would like to say to that person too is the American Cancer Society, they do have a lot of resources that we really don't know about. And I would definitely suggest that you go online, get a number, and contact someone there for resources, as far as any resources you might need. Support groups, for myself, the hospital that I had my treatments, they had a support group right there. There are other hospitals that have support groups right there. So if you spoke to your doctor or whatever, they would point you to some support groups. And also you can look for the Healing Stream Breast Cancer Awareness Organization on Facebook, and our information is there. We too have support for women who are going through breast cancer.
Great. Thank you, ladies. Thank you for all the input, and your stories are riveting and encouraging, to say the least. Right now, I am going to turn it over to our President, SAR Nicole Carmichael, who is going to greet and release us for the evening with a closing.
Hello, everyone. Hi, welcome to the Breast Cancer Virtual Awareness Forum. I hope that you enjoyed yourself and received some invaluable information. I'd like to thank Dr. Amine with providing us with this information and the other Shiros for sharing their testimonies. Early detection, diagnosis is key. That's what I heard Dr. Amine say. So that is what is key to managing and or surviving this disease. I'd like to thank the Health and Wellness Committee for organizing this event and also our Information and Communications Committee for providing all the technical assistance. We know we need them. And lastly, but not least, thanks to all of you who took your time out of your busy schedule this evening to attend this event. Thank you.
Okay, thank you. And just as a reminder, there is a survey in the chat. If you would be so kind, it's also available on Facebook to fill that out and give us your feedback so that when we do this again, we'll do it even better than we did tonight. So thank you very much and have a good evening.
Thank you, everyone. Everyone stay safe and be well.
Thank you.
Thank you, Dr. Amine.
You're welcome. Take care. Good night.
Good night, everybody.
Good night.